السلام عليكم أعزائنا الطلاب. محاضرتنا اليوم على الدايابيتك فود. First of all, diabetic foot is a complex disease that can develop in the skin, muscle, or bone of the foot as a result of the nerve damage, poor circulation, and or infection which is associated with diabetes. Other definition by WHO, diabetic foot may be defined as syndrome in which neuropathy, angiopathy, infection will lead to tissue breakdown, resulting in morbidity and possible amputation. Other definition, any foot pathology that results from diabetes or its long-term result. Epidemology, 15% of adult population in Arab world are diabetics. 15% of those with diabetes will develop an ulcer. 15% of patients develop osteomyelitis and other 15 ends with amputation. 80% of foot ulcers are precipitated by external trauma. 20% of diabetics admitted to hospital because of foot problems. Cellulitis occurs 10 times more frequently in diabetics. Osteomyelitis of the foot 15 times more frequently in diabetics than non-diabetic. Diabetic patients are 15 times at risk of below-knee amputation. Nearly half of non-traumatic lower limb amputation caused by diabetes. 70% of lower limb amputation begin with simple foot ulcer. Approximately 50% of diabetics with lower limb amputation require second lower limb amputation within 5 years. So 5-year survival rate approximately 50% after below knee amputation. This is tragic rule of 50. The annual direct and indirect cost is high. Up to 85% of amputations can be avoided. This is very important point. Prevention is very important in diabetic foot. Natural history of diabetic foot. It is unwise to consider that major diabetic foot problem occur all of a sudden. There is high-risk foot, which means, what is the meaning of high-risk foot? High-risk foot means long duration and uncontrolled diabetes mellitus plus one or more of the following: peripheral neuropathy, peripheral vascular disease, trauma, previous ulcers, diabetic neuropathy or retinopathy, obesity, lack of education, and if the gender is male. This picture about certain diseases which make the foot more susceptible to ulcer and susceptible to amputation: deformity, neuropathy, vascular, previous trauma. What is the main pathophysiology of diabetic foot? Critical triad of neuropathy, foot deformity, and trauma will lead to ulcer. The presentation is the majority of patients as an infected ulcer. This neuropathy, foot deformity, trauma leads to infected ulcer. Very important to understand what is the neuropathy and how the neuropathy plays a role in developing foot ulcer. You have to know that neuropathy can be sensory, lack of protective sensation, motor, change in foot anatomy, pressure point, and altered gait and deformity of the foot, and even autonomic, lack of sweat, dry and cracked skin. Pain, the gift nobody wants. Pain, the gift nobody wants. Keep this in your mind in treating patients with diabetic foot ulcer. Stages of ulcer development. There are many systems. First of all, stages of ulcer development starting by callus formation, thickening in the skin. Second, by simple trauma or pressure, there is development of subcutaneous hemorrhage, subcutaneous hematoma. After that, development of an ulcer, breakdown of skin. This ulcer extends deep to involve the tissue downward and even goes to the bone, leading to osteomyelitis, infection of the bone. Assessment of patient with diabetic ulcer, careful history, careful physical examinations, full investigations of the patient, examination of the lymph and foot, and examination of the wound. This is deformed foot for patient with diabetes mellitus. This foot is at risk and the patient is liable to develop an ulcer since there is a deformity. There is a pressure increase at the base of the first picto, especially if the patient has a sensory neuropathy. So feeling of pain and feeling of any painful stimuli cannot be measured by the patient. It is liable to develop a neuropathic ulcer in such case. Assessment of patient with sensory diabetic foot. Look for temperature of the foot, vibration sense, pressure sense, light touch, proprioception, superficial pain by pinprick, and reflexes. Assessment of an ulcer, size, and shape of the ulcer. Edges, establish its depth and involvement of deep structure. Examine for purulent exudate, necrosis, sinus tract, and odor. Assess the surrounding tissue for sign of edema, cellulitis, abscess, and fluctuation. Of course, we have to perform vascular evaluation. The ability to gently probe through the ulcer to bone has been shown to be highly predictive of osteomyelitis. Establish the ulcer etiology, exclude systemic infection, septicemia, and bacteremia. Very important classification is Wagner grading system for diabetic foot ulcer. This classification, according to the skin involvement and underlying involvement of the ulcer. Grade 0, skin intact but foot at risk. Grade 1, superficial diabetic ulcer and localized ulcer. Grade 2, deep ulcer and extension of the ulcer downward to the ligaments, tendon, joint capsule, or fascia. But there is no abscess or osteomyelitis, so we are in grade 2. Grade 3, there is deep ulcer, but osteomyelitis and abscess formation. Grade 4, gangrene to portion of forefoot, localized gangrene. Grade 5, extensive gangrene of entire foot. These are pictures showing the grading system of Wagner. Grade 0, just deformity. There is no skin ulcer. Grade 1, there is a localized ulcer. Grade 2, there is an ulcer. And extension downward to the tendon, but there is no abscess and no involvement of the bone, no osteomyelitis. Grade 3, there is involvement of deep tissue, tendon, ligaments, fascia, capsule of the joint, and reaching the bone. Grade 4, localized gangrene. Grade 5, extensive gangrene of the lower limb. This is a typical picture of neuropathic foot ulcer when there is an ulcer overriding the bone deformity or deformity of the foot. Foot ulcer, when it is neuropathic, is not terminal, not at the toe. It is important to assess vascular system of the patient by history, changes in skin, pulses, exercise test, Doppler study, and geography. This picture showing ischemic foot ulcer, ischemic gangrene. The ulcer is at the end of the foot, blackish in color, non-infected, and we see that it is a dry gangrene because of vascular occlusion. Assessment of infection. Infection is diagnosed clinically by presence of purulent secretion or at least two of cardinal local manifestation of inflammation: hotness, redness, swelling, function loss, or pain at the site. According to infection, diabetic foot ulcer can be classified into non-limb threatening infection, localized skin infection. Other type of ulcer is limb threatening infection ulcer. This ulcer is large, extending, and involving the deep structures. Thanks.